Good afternoon, and welcome to the Beyond the Blueprint webinar series. This series empowers health IT professionals with the latest insights, strategies, and design principles required to seamlessly integrate design tools within their projects. Whether embarking on a hospital remodel, constructing a brand new facility, or undertaking a targeted renovation, technology and innovative design is playing an increasing crucial role in shaping the future of healthcare delivery. In this series, we explore how to successfully integrate leading-edge technologies and design processes to enhance patient care, optimize operational efficiency, and to drive a positive and compelling ROI. My name is Greg Malkery. I'm the Managing Director at Spyglass Consulting. I'm also the host for this series. Joining me is my co-host, Keith Washington, a renowned serial entrepreneur and respected board member at Companions in Courage. Keith, do you have any opening remarks for today?
Yeah, thanks, Greg. So just to remind us of sort of our mission and vision for Beyond the Blueprint, that it was created to bring design thinking into this conversation about digital transformation, to empower clinicians, to improve patient safety, to improve patient engagement, and really create a process of innovation around care team coordination. So excited to have Saroj today and looking forward to the conversation.
Well, I'm also pleased to introduce our guest speaker, Dr. Saroj Misra. Saroj is the Chief of Family Medicine at Macomb Oakland Hospital, which is part of Ascension Health in southeastern Michigan. Saroj, welcome to our webinar. Would you like to introduce yourself?
Well, thank you so much, Greg and Keith. It's a pleasure to be here, and I'm excited for the opportunity to talk today. As you mentioned, I currently serve as the Chief of Family Medicine for Ascension Macomb Oakland Hospital in Southeast Michigan. I also serve as the Associate Dean of Clinical Affairs for the A.T. Still University College, Kirksville College of Osteopathic Medicine. A large part of my work is both on developing implementation items for healthcare within the trenches, as well as the considerations for undergraduate and graduate medical education in terms of thinking about how we bring technology forward into not just patient care, but education.
Great, thank you. Now, before we dive into our discussion today, I want to express my gratitude to our valued sponsors, Storage Systems and Simplify Medical. Today, we have Lars Anderson from Storage Systems. Lars, would you like to share a brief welcome with our audience today?
This is Lars Anderson with Storage Systems Unlimited. We're a distributor of a number of different storage items, including telehealth carts, partner with our good friends over at Simplify. So looking forward to a nice education here on how things are developing and where we're headed.
Thank you, Lars. During today's webinar, Saroj will discuss how digital innovation can help enhance patient engagement and improve clinical outcomes. He'll explore the integration of digital tools into different healthcare settings and workflows. He'll showcase some case studies that demonstrate successful digital transformations, and he'll identify effective change management strategies to encourage healthcare teams to adopt digital tools. So with that, why don't we get started? Saroj, given your background as a healthcare leader and head of medical education, how do you approach the systematic design for integrating digital tools within different care settings and different clinical workflows? And secondarily, if you can help provide us a framework regarding people, processes, and tools for creating a comprehensive strategy, I'd appreciate that.
Yeah, for sure, Greg. I think when you think about systematic design, you always have to start with sort of the whys from the stakeholders. So in the environments I work in, our stakeholders are threefold. We have the patients themselves, right? We have the healthcare system as a whole, and then we have our learners, the students, residents, fellows, who are all in the process of developing their medical skills. So we have to understand when we're developing an approach to integration of technology, digital tech, and these kind of things, what are the goals that we hope to achieve? We are in an age where there's a lot of really cool and neat things out there, but cool and neat is not enough. We need to know how those cool and neat things can actually enhance or further the missions and maybe the goals that we have for each of these things. In that regard, we often think about the IHI's quadruple aim, looking at the concept of higher quality care at a better value, with better outcomes for the general public and a better clinical experience for physicians. These four tenets are critical to ensuring that our healthcare system is considered not only effective, but efficient and high quality overall. So with that in mind, we have to then start thinking about, like you said, the tools, the process, the system. What I believe is always important is that you have to have a committee or a group that's made up of a few different individuals. First of all, you need to have the people who are sort of the visionary thinkers, who are able to actually come up with a cohesive vision and are able to identify that cohesive vision by communicating effectively with the stakeholders. In our case, we have a few what we call technology visionaries who actually meet with our stakeholders to say, what are some of the things that don't work? What are some of the things you wish would work better? And in an ideal world, what are the things you wish you had that we don't currently have? So we ask our patients, we ask our physicians and our nursing teams, and we ask our learners. And this gives us a starting point for thinking about what we are trying to accomplish. The next group of people that have to be involved are the people who you consider the let us call them the logisticians, right? These are the individuals who can take these concepts and identify specific projects or initiatives or programs or technologies that can achieve those visions that are identified. And so these are the people who are, the what I would call the technology wonks. These are the people who know what cutting edge technologies are out there and what they're being considered for in terms of usage. They're the people that are looking at and reading current studies and articles. They may be people who have specified specific fellowships in different healthcare technology domains. And they're the ones who can say, once somebody tells them, this is what we're hoping to do, they can say, I think these ideas out here or these concepts are the ones that we can bring forward from these initiatives or these projects to accomplish that goal. And then the last thing you have to have is you have to have people who serve as sort of an evaluator of the system, I think. And they need to be there to do two things. The first is to really say, what are going to be the metrics, the outcomes, if you will, that tell us that these initiatives are worth doing because they actually do achieve those missions. And also, they're there to identify what are the potential barriers that exist to integrating and adopting these kind of technologies as we move forward. You might say, well, why can't that be the same one of the other groups, like the leadership or visionary group? And the reason is because I think that once you start to ask people to do two different roles, it becomes very different to get a sort of clarity of purpose and an efficiency of action. And so we need to have a group there that's sort of looking at all of this and saying, okay, but when we pull this string in the yarn, it tightens this portion of the ball. So how do we account for those things? So that is in my mind, Greg, how you start to develop not only the why we do this, but the framework of who needs to be involved in the doing of it.
Great insights. I like your focus on balancing human and digital interactions. I also like some of the key points we discussed offline about how technology should enhance and not replace the patient-caregiver relationship. Keith, what are your thoughts? Any thoughts on this topic?
Yeah, no, I really I appreciate the detail on thinking about the different stakeholders and their inputs into the design process. So I guess when you're putting these teams together, are you kind of identifying like who would fill each of those roles, or I guess is each team member thought of as they may say have a strength in one but then contribute to all three? I guess how do you think about that when you're deciding who's on the team and maybe how the team works together?
Yeah, that's a really important point is, what we sort of talk about, because the risk you have is that if there's not collaboration between these groups, right, you have siloing, right? And you have a loss of perspective. So our goal is not to necessarily find somebody who's an expert in this thing, but only knows this thing, but somebody who that maybe has some knowledge, a little bit more knowledge and a better sense of it, but also is able to collaborate and know some of the other domains that we're talking about. So if you imagine, you might have your group here in one bubble, your group here in one bubble, and your group here in one bubble, but really those bubbles would have a sort of Venn diagram overlapping, right? Where people may have some relative skill in one of the other domains. I think that's a far more important thing than necessarily getting the top expert in something, but they have no ability to recognize vision, no ability to, for example, and stuff like that. I'll take the person who can collaborate and know a little less than the person who knows everything but can't collaborate every day of the week.
Perfect. Thank you.
Saroj, could you provide us a specific example where a digital engagement program helped improve outcomes and experiences, and maybe share some best practices or lessons learned from as a result of your oversight?
Yeah, for sure. So one of the things that our healthcare system embarked in a few years ago is in thinking about patients as stakeholders. What we heard from patients is they felt like the input that they gave on surveys and feedbacks was not really being heard. They said they never really heard any outcomes from that. So let's say, Greg, you go into the hospital and you have a surgical procedure. Before you leave the hospital, you'll be asked to fill out a survey card, and that card then ostensibly gets reviewed by someone. But you as the patient never know if your opinions and perspectives, if they were shared, how they were shared, and how they contribute to the larger volume of data that the hospital system is taking in about the patient experience. So we started to revise that and look at what can we do to do a better job of that. A few of the things that we started to do was moving from paper to digital implementation of this, and actually removing creating a small amount of time delay there to allow one thing the patients told us is that having to complete that while they're still in the hospital can be a little bit challenging because they're still, in the process of recovery and they have so many other things they're trying to do, right? So we started to actually do this digitally, but a week after their discharge from the hospital, giving them enough time to reflect on the overall care experience. We started to use Qualtrics as a way to take this data and make it meaningful to our leadership teams. So up until that point, our data had been sort of reviewed by individuals who would present some limited reports on the outcome data. But once we started to use data analysis like Qualtrics and other data analysis programs, we were able to come to more meaningful outputs from that data and more clear pictures of what patients were trying to tell us. And so that, I think, is one example within our institution of how we're using and have used digital health, digital technology, digital tools, whatever you want to call it, to improve experiences. We've noticed that since doing that the messaging for our leadership teams on patient experience has been much clearer. But the other thing the leadership team is starting to think about and has started to implement is how do we turn that messaging back into marketing for the hospital system to the community? So once we know what patients value, how do we take those values and show the community that we're actually implementing those values, right? And that wouldn't have been possible before without the ability to look at large amounts of this data and even starting to use augmented intelligence to develop some generative ideas or generative talking points. That's one example in our hospital. But another example that I want to point to is a company that's working with a product called Theater. Theator. And I'm not here to, obviously ascribe to any single product, but I find this very interesting. So what this product is doing is this is essentially the ability to record surgical procedures as they're occurring and then use machine learning, augmented intelligence to actually assess the competency or the overall performance of the surgical team. Using that information then to drive education for improved performance for surgical teams, right? And so this is a fascinating idea because what we're really saying, surgery and surgical subspecialties are very, very still mentorship driven, right? So whatever I, as a learner, a surgical learner, I'm going to do in my future career is almost entirely predicated on the people that teach me. Whatever suture they use, that's what I'm likely to use. Whatever incisions they make, those are the ones I'm likely to make. And so what you end up having is this very sort of mentorship-driven approach, which isn't bad, but it doesn't tell the whole picture of competency. Because your mentor may not be completely aware of additional and newer techniques or better techniques and things like that. So one of the questions is, how do we use technology to improve performance and improve learning? And I think this is an example of where AI and machine learning can be particularly useful in accessing a broader database of knowledge, which can then be used to drive better learning and better performance.
I loved how your team is continually adjusting and improving the process over time. And I love the fact that you guys are now leveraging a lot of the augmented AI-based tools. I think that's very encouraging. Keith, do you have any thoughts on this topic?
Yeah. I just want to follow up maybe on, I'll call it the attitude of the team. I guess as consumers, we're just surveyed all over the place. So there's a lot of that going on. So I guess in terms of the attitude, do they feel like this is something that is authentic and you're really getting benefit, or is it, just analysis paralysis? I guess give me a sense of how that's been going over time in terms of the adoption.
So, I think you're absolutely right, Keith. There's always that concern about like over surveying. And, it's sort of like, I think Albert Einstein said it right. Not everything that can be counted matters, and not everything that matters can be counted, right? And the question is always, are we counting a lot of things that don't matter, right? Are we assessing a lot of things that don't matter? And so I think that's become the question. And that's why we've started to turn around some of the information from those surveys to show patients that, in fact, their comments do matter and how those are changing our approach. So that's been a big thing that our marketing team has been working on, is how do we take what we learned and how do we turn that around and show people, hey, this is what you said, and what you said, this is how it's driving what we're changing. So I think the key there is people don't mind doing surveys to an extent if they know that the outcomes from those surveys are going to create some new experience, new opportunity, new growth. The key is that you have to demonstrate that. You have to be showing in very public ways what are those outputs that demonstrate that we learned from what you told us. So I think that's an ongoing work in progress. I don't think anybody has hit it quite perfectly, but I think you're starting to see a lot of parallel thinking lines in different institutions about, we're making a lot of changes to improve process, but are we doing a good enough job of sharing and being transparent about that?
So I guess just one quick follow-up on that is that, are you doing it at sort of a broader marketing level, or I guess how does the individual get that feedback, or is it a little bit of both, or how do you think about that?
I think it's a little bit of both. Obviously, the individual feedback is using, at least in our institution, is kind of the same way that we've done it historically. And that doesn't mean there isn't room for improvement, which is we usually have a care manager following up with the patient to assess their experience, review if there was anything of concern on the patient survey that was completed, as well as the primary care physician. So when the patient comes back to the primary care physician post-hospitalization, primary care physicians are being taught and told to ask about how was the experience in the hospital, what were some of the concerns, what are the things that went well, and then that information is fed back too. So you're sort of getting a redundancy of information, but it's useful because over time and with different people asking the question, you may get slightly modified answers. And that's the individual level. And then I think at the macro level, it goes back to that concept of how do we market this? How do we invest in this? So in our hospital, we have obviously a medical executive team. We have dollars that, are there for initiatives. And so we're looking at what initiatives would best demonstrate that these things that have been taken in data-wise and these, if you want causative statements or causal statements, are being utilized and being implemented in the hospital. So that's where that's kind of being done at a macro level.
That's very impressive. Thank you.
Saroj, what are some of the common operational barriers you've encountered when implementing some of your digital engagement programs, and how did your team overcome some of these barriers?
So I think there are all, broadly, you can say that there are four main barriers, I think, that you always have to deal with whenever you're talking about implementing technology or applying technological value, initiatives to existing process. So the first in medicine, and certainly one that I think is always on the forefront of people's minds, is data privacy and security of data, right? Unlike many other industries, and I don't mean to talk down any other industry, but healthcare data is an extremely sensitive type of information. Within it can be information not only about medical conditions, but things that can be utilized in potentially adverse ways if that data is released to people in the wrong approach. So data privacy and security is always, I think, one of the first things that you have to think about as a potential barrier. And so the approach there, again, is that you need to be sure that when you're looking at products or ideas or things like that, that can be utilized, that the data privacy is considered. The second barrier, if you will, in my mind, is the attitudinal barriers, right? So people may not feel comfortable. And that's a natural human thing, right? We aren't comfortable with what we don't know or what we don't have competency in. That's true of all humans. It's particularly true in the medical field, where often we're expected to have a high degree of competency and excellence in everything, which isn't really feasible as technologies, especially in medicine, move forward on a day-to-day basis, right? So, the person who trained 10 years ago, a large majority of the technologies that may be used and leveraged today are not ones that they were introduced to during their critical training times. So we have a natural tendency to be nervous when we're adopting new technologies that we ourselves don't have competence in. And the approach there is you have to do a lot of education, and frankly, you have to find champions. What we tend to look for are champions in each domain: nursing, physicians, etc., in an effort to ensure that there are people that other people who feel less confident can look at as leaders and say, well, if so-and-so is adopting this or can do this, then I can do that too. As well as those people may be able to translate certain ideas into languages and analogies and frameworks that people who are on the fence about it may understand better. So I think that's one of the other things that you have to think about. I work in a very large system, so the third barrier, I think, is interoperability and integration. Like, how well does this mesh with our already existing complex system? So we have a fairly complex system. At any given time, we have, anywhere from 5 to 10 to 15 different systems, if you will, electronic, technological, that are running in parallel to keep the healthcare system moving forward. Anytime you're going to add a new technology or a new initiative to your system, you have to know, how well is this going to play with others? What will be the balancing and limiting factors, if you will, when you introduce this new technology, this new process? And is there enough gain on that to justify the adjustments that you may have to make in your existing things? This goes back to that other concern from the humanistic side, which is, hesitancy about it. There's a lot of, if it ain't broke, don't fix it, or why should we fix it, right? And the real answer to that is, just because something isn't broke doesn't mean it can't be better. And when it comes to caring for patients, we should always be pushing to be better, right? So the last domain I think that I haven't really addressed as a potential barrier is cost and return on investment. For any large healthcare system, if they're going to invest in new technologies, it's generally going to be a significant investment that they're going to do. And that's because you can't really scale things up without that initial large investment. And so healthcare systems have to know, or have to have done some really good due diligence to know that there's going to be a return on investment, right? Nothing retards future adoption of technologies like a project that you invest a lot of money in and then you drop it 2 years down the road or 3 years down the road. That leaves a bad taste in the mouth of essentially all the stakeholders in the system. So there has to be a real understanding of what is this going to cost us, not just financially, but logistically, because there's a logistic cost to these implementations. And what's the return on investment? And this is where I would suggest that it's important for organizations to go back to their stakeholders, because the return on investment is not always a financial or tangible number return. There may be intangible returns like making patients feel more secure or feel more valued as part of the experience, making physicians and the healthcare teams feel more valued. Those are meaningful returns on investment as well, right? But they aren't necessarily ones that you can easily calculate. So I would suggest to you that those are the 4 barriers that we often think about when we're trying to decide what technologies and what new integrations we're thinking about.
Great. Great, thorough insights. Keith, is there anything you'd like to add to that from your background?
Yeah, and I appreciate sort of the uncertainty and the journey into the unknowns. And you talked about how, let's say on the patient side, there's like a feedback mechanism. Does staff have a way to give you like more real-time feedback or interim inputs as to, is it going the way we thought, or is this something we need to put the brakes on?
Yeah, I think, it's interesting because I think patients often come into the experience thinking that they are the subjects and they're being treated, not really realizing they have a voice, which is why we have to work harder with them. But actually, I believe our staff believes, as long as they believe they're working in a safe and secure environment where opinions and perspectives, even if they differ or disagree, are respected, they're ready and willing to contribute their perspectives and stuff. So I think that's actually a lower lift than getting the feedback from our patient stakeholders. But again, you heard my caveat in there, right? The caveat is that the environment has to be one that says perspectives, opinions, even if they are different, are valued, right? And you have to know that if I offer up something that says this system that you guys are working so hard to adopt, there are some critical flaws that we're noticing in implementation, and we have to share them with you. If you think by sharing them, your job is at risk or your status is at risk within the system, you're likely to not offer up that information. So we need to continue to make sure that our employees, feel that they have an environment that allows them to do that.
Excellent. Yeah, and you feel as a leader that your organization reflects that? That's sounds like
we're trying. We're trying. I think it's a journey, right?
Yeah.
There's never you never hit it perfect.
Sure.
And I certainly know both on a macro level, our institution continues to work at that. On a personal level, I continue to work at that. I think that's a humanistic goal we all should have. Actually.
Excellent.
As far as change management is crucial when adopting new technologies. Based on your leadership roles, what strategies are effective in motivating teams to embrace these tools and to actively integrate them within their workflows?
Yeah, so I think in terms of motivation, which is a really important thing, right? You have to have people motivated, dare I even say excited about the implementation of these tools. And that's a very high bar because all of them know that integration of new tools is going to likely mean, more work in the short term, right? And a degree of lack of competency, which leads to that psychological unease, right? So how do we motivate them? So the first thing is, and this is why that understanding your stakeholders, needs and goals is so important, is that you start by sharing the vision and sharing which part of the vision applies to them. So for our patients, right, explaining that there may be some new tools that we're implementing that ask them to do some additional things. But if you start by saying, but this is designed to give a better patient experience, not just to you, to other patients. And by better, we mean more efficient, more transparent, with hopefully idealized outcomes, right? That is the kind of motivating thing that you need for that. For employees, it's the promise of a more efficient and effective system, one that works the way it is. Any person who works in a healthcare system only needs about a month to tell you how the healthcare system is failing, right? The flaws are often obvious when we are in the thick of it, right? And most of us who are in the healthcare system want those flaws to be less of a flaw. So I think showing how that new implementation can reduce existing flaws, right, and improve and streamline inefficient processes in the delivery of healthcare is a meaningful and powerful thing. So I think you have to think about that motivation. I think the caveat, Greg, though, is that you have to recognize that there are some people that no matter what degree of, showing them the what's in it for them, there are going to be people who are always going to be naysayers. And then you have to make some challenging decisions. You have to decide, who is this person? What's their role within the larger organization? And how resistant, recalcitrant are they? And then you have to work on, do I need to do more targeted work with this person or this group to bring them on the bus, if you will? Or do I have to say, thank you so much for riding with us this far, but this is your stop, if I can continue this really bad vehicular analogy.
Great. Hey, thank you. Well, our research confirms that if you can integrate the tools within clinical workflows, you can significantly enhance provider efficiency and also improve quality and outcomes. But we also found that you can't get patient engagement unless you have strong staff engagement. These patient engagement programs tend to struggle. Maybe you can just comment briefly about that.
Yeah, that's a really good point. And I think the two go hand in hand. When a patient is in the hospital, you have to think about, and we talk about this all the time with our learners, who do the patients interact most with? It's not the physicians, right? They may see the physician for a very short period of the time of the day, right? It's usually the nursing teams, the ancillary healthcare teams, and things like that. So it's reasonable to also think that patients, the people that they know best in the hospital, are going to be the people who they listen to the most as well. Even with the doctor's stature, if that doctor is not able to communicate effectively, or the patient feels like the doctor is not being kind or caring in their approach, which unfortunately still happens a lot, right? They're going to turn to the rest of the team to kind of understand what is important. So it's really important that, as you talked about, that our allied health partners, our nursing care teams, our therapy teams, right, all of these other people that interact on a daily basis with the patients in the hospital environment are able to pass along the message of, hey, here's what's really important. Here's what we need to do. Here's why we're doing it. And by the way, here are these tools that we're utilizing. We really need you to participate. So I think that if you don't engage the staff, listen, I'm a physician. I'm just going to tell you, if you think that you're only going to get there by having the physicians do it, you're not only not going to get there, you're probably going to fail pretty spectacularly. The day and era of the physician being the only voice in the room that matters is long gone. And we need to recognize, yes, physician-led teams are critical and highly important, but we have to remember the team has a significant value in the overall patient engagement in their health.
Wow, great insights. Keith, anything you'd like to add?
No, I think it's sufficiently challenging as you're saying. I think that maybe just one comment about how do you keep, you're very upbeat. How do you stay so upbeat in this context?
I think it's hard at times, of course, especially when you're seeing, things. I think you can be upbeat, or at least I'm upbeat because I'm realistic. I'm not trying in my leadership roles to move the needle all the way to the right, because if that's my metric of performance, I'm going to fail every time. What my goal is always is, can I move the needle a little bit more to the right, so that the person who comes after me can move that needle a little more to the right. And I think when you start to look not at the end point of where we want to be as your metric of success, but how do I achieve that next plateau, that next step, that's much more manageable, achievable. And I think it's what keeps me optimistic. In the grand scheme of moving us to a place where we are fully integrated with digital technologies and we've done it all, I am a failure. But in terms of getting us to a place where we have some more people on that are the right people, our patients are slightly better engaged and understand the integration of these things, and our team is willing to do it, I'm a success.
Great.
Thank
Thanks,
you.
Saroj. Okay, Saroj, how are health leaders measuring ROI and success metrics for these programs? I think we alluded to this a little bit earlier. And could you help us identify some innovative approaches or best practices for assessing patient satisfaction, outcomes, or operational efficiency?
Yeah, I think that there's a lot of ways to look at this. And, it's like any other industry. You can look at the qualitative and you can look at the quantitative breakdown, right? So the qualitative really, I think, comes from surveys, but more so listening sessions. If I had my way, every patient when they were discharged would have a 15 to 20 minute listening session either prior to their discharge or a week after their discharge, where someone just listened to what their overall thought about their experiences were and could do that, right? We recognize that that's not a resource efficient approach to it. While it may yield high quality qualitative data, it's not feasible to do. So I think the question is, how do we craft better questions to ask our patients, right? And this is actually a very interesting area where I think that augmented intelligence and machine learning can be particularly useful to help us to start to draft better patient surveys to yield data and commentary that's more meaningful to our goal and stuff like that. I think that's one thing, is looking at that patient element as a qualitative element. You could do the same thing with your staff and your teams as well, especially whenever you're talking about a new initiative. And then I think you have to look at the quantitative elements, right? And there we are still using a lot of the same metrics as has been traditionally used. So obviously the financial over-unders, if you will, are one thing. Length of stay in the hospital is another thing that is constantly looked at, right? Rate of error, rate of infection, rate of fall. Many of these markers that might indicate an adverse outcome, these are quantitative data points that can be looked at. I suspect, though, that in the future, as we move to systems where error is less common because it's human error factors can be somewhat reduced by better training and systems that can sort of overwatch it, I think we're going to be looking for different quantitative data. We're not going to be necessarily looking for data that shows us how poorly we did, but perhaps new data points that are measures of efficacy. For example, what is the likelihood of an individual to come to our ER versus another hospital ER in the future? Now, why does a patient choose to go to an ER? Well, there's two reasons. The first is severity of the problem and proximity, right? Like, so, hospital A may be the best hospital in the world, but if I'm bleeding out and hospital B is 2 miles away, I'll go to hospital B every time, right? But also the other metric for why we choose an ER we go is perceived quality of the hospital itself, right? So that may be a quantitative data piece that is unique to look at. And again, this is where I also think that augmented intelligence can start to assess what are true quantitative measures that have meaning in the overall trajectory of hospital or healthcare system success. And I don't have those answers yet. I don't know what the new quantitative data is going to be, but I do believe that the qualitative data will always be, what do we hear from our stakeholders?
Interesting insight. I guess there was a conference I was at a couple of years back that talked about how a lot of organizations, top tier medical centers, are actually embracing this whole concept of the huddle. But it's much more extensive than just the clinical team. There's all aspects of the team, including efficiency, et cetera. I thought that was an interesting method, but also potentially overwhelm the patient.
It absolutely could. The huddle is a fascinating and useful tool when implemented correctly. I think that you can use the huddle in a lot of different ways. But let me propose an idea of a way that the huddle could move forward, utilizing and leveraging some of what AI and machine learning and some of these other technologies can do for us. So if you could have a number of qualitative and quantitative data points brought together, and then have an AI analyze that, and then present out some of the information to a team in a huddle, a multidisciplinary team consisting of an executive, consisting of a patient discharge or patient planner, a physician who may have been the admitting physician, and the chief nurse for the patient's stay, right, while they were there. And then they can read this report and discuss, what did we learn from this, right? You can get a meaningful intervention there, because now you have all the right people looking at a shared mental model of what the outcome was, and then utilizing that mental model to start to determine what changes need to be made to the system in the various domains to make the next experience even better. And this, I think, can be some really fascinating work that may come out in the future.
Great insight. Keith, you have anything you'd like to add to this topic?
No, not really. I think it's very insightful to really think of it the way you're talking about it as, augmented, it's supplemental, it's supporting, it's not instead of, it's not substituting. Yeah.
No, I mean, I think that one of the things that has really changed in the vernacular in the last 2 to 3 years, we used to use AI as a term to represent artificial intelligence. But most of the thought leaders now are looking at the current versions of things like ChatGPT 4.0 or, Gemini or, Copilot, whichever ones, as augmented intelligence. That's the new AI terminology, if you will. And really, I think that's a more accurate representation of what we're seeking to do with this technology. Not think for us, but think alongside us and give us thoughts and ideas that should prompt us to come to different thought pathways or new thought pathways and come up with creative new decisions.
Yeah, or I think you also mentioned how it can provide that oversight role. So if there are blind spots, it can avoid errors and that kind of thing, which is obviously a huge benefit of this system.
Yeah. And one of the things about augmented intelligence that is both a benefit and a risk is, like, for example, talking about, for example, that product that can overview a surgery, right? There's no bias there. So what it sees, it can see and it can report out. It doesn't take into account if you're the head of surgery or you're a resident, right? It just tells you what was seen, what was observed, and how does that compare to the repository of knowledge we know about this thing. But we also have to recognize that alone isn't enough. There are all sorts of, using the same surgical analogy, there are all sorts of minor errors that occur that are human error, right? But not every human error is necessarily something that results in a catastrophically bad outcome or even an adverse outcome. But technically it's still an error, right? For example, Keith, when you pull into a parking spot, right? You park your car, but sometimes maybe you're not exactly in the lines, right? And what do? You back out and you straighten your car out, right? Technically, your driving created an error. Does that mean that the outcome was necessarily bad and anything like that? No. But if you were able to have a machine tell you that, hey, 80% of the time you don't park between the lines on your first attempt, and if you try this technique, 80% of the time you will, right? That's where we can utilize this. But we have to be careful that these things are utilized as an opportunity for improvement. If we start to utilize these as a way to penalize people for performance, that's where I think you're going to have a real hesitancy and resistance to adopting them.
Yeah, exactly. Yeah, voluntary versus coercive.
Exactly.
Yeah.
Hey, Saroj, our final question is probably near and dear to your heart. How do you see digital tools and technologies transforming medical education and training?
Yeah, Greg, I knew you were going to come to education, and I really appreciate that. You are right. This is near and dear to my heart because I think that this is where we have the greatest potential opportunity for success. And that is really in leveraging these tools to better educate, but not just better educate, but create a better system of education for our learners. It's important to understand that these technologies can allow learners to learn new things in a safer environment more quickly, but most importantly, get more effective feedback that helps them to course correct their performance and achieve successive levels of competency quicker. That's the dream that we have now. So, for example, let's take this very esoteric idea and break it into a tangible thing for a minute, right? So we know we've had for years, the ability to look at or run a simulation of a cardiovascular or cardiorespiratory failure, like where someone goes into cardiac status or respiratory status where they stop breathing, their heart stops beating, right? And we've been able to simulate that, and then we've been able to have our learners actually move through that thing, right? But what we haven't had is necessarily the opportunity to give feedback in a very specific and discrete way, and more importantly, to use that feedback to tailor the next experience for that learner. So let's say Greg goes in to do this, run this code, right? And Greg does a great job with identifying the fatal rhythm that is occurring. But Greg turns out to be a little bit weak on which medication regimen or protocol he should be using, right? So the AI can identify that, can give that feedback to the learner, but then can craft a new scenario that specifically tackles that problem in a more involved way to give Greg more practice. And by the way, the AI can generate 7 or 15 or 30 scenarios for Greg to do that, right? So what we have, I think, with the starting to use augmented intelligence in this way is the ability to create not only more realism within the learning experiences, but also more custom tailored successive learning experiences to address the relative weaknesses or challenges of individualized learners. That's not something we've had or the ability to do because it requires a degree of complexity and, frankly, time that the average human being can't do. But now technology can start to do some of these things. So I think that's one example of how we can start to see where these technologies are going to be very, very important, not just for the learner in how they learn, but in the entire way we teach medicine.
Great. I love this idea of continuous lifelong learning and innovation, which is
Yes.
also around the whole idea of the CME, right? The continuing measure of
Right.
education. Maybe that could totally change. Keith, you want
100%.
to add anything to this?
Oh no, I love it. I love the thought process, and I love the idea of creating that muscle memory and that constantly improving and practicing. It's an awesome. I would think that the mastery and just having that confidence, what a huge impact that can have. That's really great.
Well, and as you said, Keith, I think the mastery comes because it's a lifelong learning process, right? So the great thing about this is that as a learner, I can generate tools and scenarios and things to practice when I'm in a learning stage, but I can still generate things at a higher level of complexity when I reach a higher level of competency, right? And so we can continue on our trajectory towards expertise. That is really a lifelong process, right? We never get there. Right. If you want to tie it back to something I said earlier, remember how I told you the technologies and techniques and things advance so fast that a doctor can find themselves quickly outdated because of the rapid advancements. But with the ability to use augmented intelligence to create new learning approaches for us that can help us to adopt these new things that have come out after our formative training years, we can continue to be learners even for the newest techniques and things and ideas that come out in medicine.
Awesome.
Well, Saroj, thank you for sharing your thoughts. You provided some valuable insights today where you discussed how digital innovation enhances engagement and outcomes. You explored the integration of digital tools into different settings and workflows. You showcased some great case studies that demonstrate successful transformation. And you identified effective change management strategies to encourage and motivate care teams. Now, our discussion today kind of aligns closely with some of the results of Spyglass's recent study on digital engagement that we published last year. For audience members who are not aware, Spyglass is a product and go-to-market advisory firm focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. We have more than 250 customers who are leading technology companies, consulting firms, healthcare providers, and investment organizations. We've published more than 30 market research reports on various informatics-related topics around mobile computing, communications, digital engagement, telehealth, and clinical surveillance. So to explore Spyglass's extensive library of paid research and gain deeper insights into how technology is reshaping healthcare, I encourage you to go to my website at www.spyglass-consulting.com. Well, Saroj, I'd like to thank you once again for sharing your time, insights, and perspectives, and to our sponsors, Storage Systems and Simplify Medical. Saroj, would you like to provide us any closing remarks before we conclude today?
Well, Greg and Keith, I'd like to thank you again for the opportunity to share. I certainly don't know it all, but I hope that some of the things I've talked about today have generated some thoughts in those of you who are listening or watching, and that really sparks discussions in your own environments. And I would simply say this, we're all moving towards a better place, and we have to keep moving forward. We cannot allow ourselves to become sedentary in this process of always pushing for better healthcare with more effectiveness, more efficaciousness, more cost containment, and a better experience for the physician, the healthcare team, and the patient. Thank you so much for the opportunity.
Keith, would you like to share any final thoughts on today's session?
Yeah, thanks, Greg. No, I'm just so encouraged by the leadership and design aspects of this work and this mix of tools and the usage, say, to enhance and empower and to augment and facilitate and just what it can do for clinical teams. It's got to be productive and rewarding. I love the positivity. I love the approach.
Well, at Beyond the Blueprint, we look forward to continuing our conversation with you in future episodes of this series. And Saroj, I hope we can invite you back for another edition in the future.
I would be happy to participate, and thank you for the opportunity.